8:30 we're going to begin. We have a couple of our committee members that have notified us somebody is sick, and then somebody has a family situation that they need to take care of. Others might be stuck out there and trying to get through a lot of folks that are here today. It's local government on the Hill. And I hope you enjoy getting to meet some of those folks. We're going to jump right into a hearing on Senate Bill 404. And Eileen, would you give us a bill brief? And that would be Jenna today. Thank you, Jenna.
Thank you, Madam Chair. Good morning, committee members. Jenna Moyer, Revisor Statutes Office. Senate Bill 404 would authorize the use of expedited partner therapy to treat a sexually transmitted disease. This would create a new section of law. Subsection A defines terms used in the bill. Relevant ones would be a healthcare provider, would be a physician, an APRN, or a physician assistant who are authorized to prescribe drugs. And a sexually transmitted disease would be diseases transmitted by sexual contact that are defined in rules and regs adopted by the Secretary as a reportable infectious disease and designated as appropriate for expedited partner therapy by rules and regulations adopted by the Secretary. Subsection B authorizes a healthcare provider who diagnoses a patient with a sexually transmitted disease to prescribe, administer, or dispense antimicrobial drugs to a sexual partner of their patient if, in the healthcare provider's judgment, the patient's sexual partner is unlikely or unable to be present for examination and treatment. Subsection B2 would require that healthcare provider to provide counseling to that patient, including distributing written materials developed and provided by the department to be given to the patient's sexual partner. And the rest of that section sets out some guidelines that a child who is 16 years of age or older may consent to receive expedited partner therapy when no parent or guardian is immediately available. Subsection C provides for immunity for a healthcare provider or pharmacist who complies with the provisions of this section in good faith, would not be liable for those damages. And subsection D sets out the requirements of the department to provide the information in written materials developed and provided for distribution. This would take effect upon publication in the statute book. And one more thing, if this sounds familiar, in 2021, the House passed House Bill 2259, which came over to the Senate, was heard in 2022, and it died in this committee. And I'll be happy to answer any questions.
Committee, any questions from Jenna? Senator Stephan.
Thank you. You mentioned the conditions upon which this would come into play, and I think you used the word unlikely to present this third party.
Yes, if the partner is unlikely or unable to be present for examination, testing, and treatment.
Do we have any parameters on unlikely?
This would be up to the professional judgment of the healthcare provider. And among the guidance that the provider would be required to provide to their patient would be these materials that would tell the partner, hey, this is a thing you need to be tested for as soon as you're possibly able to be tested for it, to give them guidance, encouraging to come in and explaining the risks.
Other questions, committee? Thank you, Jenna. We do have a number of conferees today, and we appreciate those who sent in their written testimony, may be here today, but they're allowing others to have the time. So we will allow 3 minutes per conferee to give us plenty of time to ask questions. We're going to begin with Patrick Allen. Dr. Allen, thank you for being with us.
Thank you for having me. I'm Dr. Patrick Allen. I'm a family medicine physician in Wichita. I help teach at the residency program in KU. Others here will testify to the alarming increases of STIs in Kansas in recent years. That's a national trend. I'd like to help kind of flesh out what expedited partner therapy looks like in practice. So in my practice, unfortunately, chlamydia and gonorrhea have become daily occurrences. And so I'd like to emphasize that these are not just minor inconveniences, that these are infections that often result in hospitalizations and unnecessary surgeries and long-term complications such as infertility and chronic pain. Perhaps the most serious complications are when pregnant women get infected with gonorrhea and chlamydia. It can lead to premature labor and delivery. It can cause low birth weight in the newborns, serious infections in the newborns. So to me, effectively treating STIs, it's not just about the patient, but I see this as a bill that could help protect unborn life as well. So when we diagnose these infections, really every effort is made to treat not just the patient, but their recent sexual partners too. And so we always emphasize, hey, your recent sexual partner needs to come in, they need to make an appointment with their physician, they need to get tested, they need to get treated. Unfortunately, in practice, that often doesn't happen. Sometimes these partners don't have insurance. Most often, the patients are young women and their partners are young, healthy men. Young, healthy men often don't have their own primary care physician or provider. Often they don't have insurance. Perhaps they're just too busy. People delay and neglect their own healthcare needs. The man is likely to be asymptomatic, and so they may not understand their need for treatment. They may falsely think that they're not infected and so that they don't need to be treated. Ideally, both partners are treated together on the same day, and then sexual intercourse is not resumed until 7 days after. So what we try to avoid is one partner being treated, and then 2 weeks later, another partner being treated, and then they can pass the infection back and forth between each other. And so coordinating treatment is really important and practically difficult. You know, if their partner calls their physician, they probably won't get an appointment right away. So for a variety of reasons, the partner, there's a lot of barriers to prevent the partner from getting treatment. So we see reinfection rates as high as 30%, and that puts our vulnerable patients in unfortunate situations. So, you know, as I talk to my physician colleagues, and, you know, we work within a Catholic healthcare system, this is
Dr. Allen, thank you so much. I believe that was our timer.
Any
and I'm
questions?
sorry to have to cut you off. And we will take all of our questions at the end of the testimonies.
Thank you for having me.
Thank you. Next, we have Anthony Jeter. Or Jeter. How did I say that?
Jeter.
Jeter.
Yep.
Thank you for being with us.
Thank you. Hello, everyone. So my name is Anthony Jeter. I'm a pharmacist practicing in Wichita. I'm a first-year graduate resident for Kansas University and Dillon's Pharmacy. The big thing that I want to focus on is, so I'm from Nebraska originally. EPT is allowed in Nebraska. It was originally signed into law in 2013. From my practice and experience with it from there, I can attest to the fact that it is, one, widely accepted, widely utilized, and it is very smoothly integrated into the workflow of the pharmacies currently. The fact that EPT is allowed up there has not caused any issues that I experienced on the pharmacy side of things, and it is very widely utilized to my knowledge. And the providers, practitioners that utilize it all seem very accepting of it and grateful for it, as many of the speakers today will likely attest, I would anticipate at least. The other thing that I want to focus on is from the pharmacy side, the medications that we use for EPT are generally very safe. There are three major medications. There's Cefixime, which is a penicillin derivative that would be dosed one time as an oral dose. So because of the one-time dose, very low risk of complications arising. Another one is azithromycin, which very, very safe, very commonly used for other infections, not much in the way of side effects that we would need to be worried about or things that we would need to counsel a patient on. And then the other more common one is doxycycline, which again is very commonly used in practice for a whole wide range of infections. The two main counseling points for doxycycline are that it should be avoided in patients who are pregnant because it can have some negative effects on the developing child. The effects would be mainly teeth discoloration, which is more so cosmetic, but it can be permanent. So we try to avoid it in children and in pregnant individuals because it can have the effect on the child. So the counseling point is we want to make sure not to use it in patients who can become pregnant or who are pregnant. As long as a patient isn't pregnant, the medication is very safe. The other counseling point is just a minor administration one. It should be separated from antacids, calcium-containing supplements, due to a drug interaction there. But again, very safe in general, very low risk of these medications causing complications. Allergies would be counseled on in general. Already we counsel patients on allergies. We check allergies against medications being prescribed, so that wouldn't necessitate any sort of change to our current workflow.
Thank you so much for being here.
Thank you.
And next we have Kimberly Kern. Welcome.
Good morning. Maybe. Good morning. My name's Kimberly Kern, and I am a pharmacist working in the Kansas City area for Walgreens Specialty Pharmacy. I'm also the pharmacist in charge for the Wyandotte County Health Department. And then I have earned and maintained credentialing through the American Academy of HIV Medicine, or AHIVE, as the majority of my patients at my practice currently are HIV positive. So I am familiar with a variety of sexually transmitted diseases as well as STIs. I'm here today to convey my support as a proponent for Senate Bill 404. I believe it'll serve the population of Kansas in a variety of ways, ideally decreasing the incidence of sexually transmitted diseases and infections by treating affected patients and their partners, all while increasing access. Accessibility to me looks like access to the physical appointment, access to a test, health literacy, cost, preventing missed work days. These are all things that I know my patients care deeply about, and if we can remove barriers to these accessibility issues, I know that more care would be provided. Without having to conduct a physical exam, we're bridging the gap and then decreasing the time it takes for patients to receive their treatment. Pharmacists have ample training and the ability to handle all the counseling required, as my colleague mentioned previously. Personally, when working in Kansas, I've seen prescriptions come through that I knew were for EPT, but we did have to seek clarification because the way the prescription was written, we weren't able to dispense with clear guidance from our state boards. And that just increases the time it takes for patient to receive care. It would not add any additional duties, time, stress to my workday because we're already providing in-depth counseling. And pending no known drug allergies or known contraindications, EPT is safe and effective. I think the more patients that can receive treatment, the greater overall benefit will be for the community as a whole. And I thank you for your time. And as you said, we'll entertain questions at the end. Thank you so much.
Thank you very much. And next we have Kelly Fritz.
Good morning. Thank you, Chair Gossage, for listening to this topic today, and thank you for the opportunity to speak. I'm an APRN certified nurse midwife and have worked with women and babies for 39 years in the state of Kansas. My career has been characterized by listening to and serving women because for the past 21 years I've been working as a certified nurse midwife. I've volunteered at the Miami County Health Department for the past 18 years. First in the family planning clinic when we had it, and now in a limited scope women's clinic 2 mornings a month. I fully support expedited partner therapy as a tool to target and treat sexually transmitted infections. The physicians I have worked with over the years and collaborated with have supported me in utilizing EPT for my clients' partners. There have been no adverse reactions or complications from utilizing EPT in any of the practices I've worked. EPT is managed by treatment regimens provided by the CDC, and you've heard how it's recommended to be used. My goal is to increase opportunity for testing, treatment, and health in the women in my community. EPT is something that can help reduce reinfection in my clients. We know that women are more likely to be tested. We are accustomed to getting annual exam visits for renewal of prescription birth control, periodic cervical cancer screenings, and are more likely to have an appointment which may include STI screening. Women also receive routine STI screenings during prenatal care due to the risks to the mom, pregnancy, and fetus. Women who screen positive are treated and recommended follow-up testing. Treatment of partners is crucial in decreasing reinfection. Young men are not accustomed to having annual exams unless they're on prescription medication and therefore do not have the same opportunity for routine screenings. They are less likely to have an established relationship with a healthcare provider. My female clients have reported their partners either initially deny that they could even have an infection, are resistant to see or find a new healthcare provider, are reluctant to be swabbed, don't have health insurance, or can't afford a doctor's visit. EPT can bypass those barriers, leading to treatment and decrease the spread of infection to others. Those barriers are what make it unlikely for partners to be tested within a reasonable amount of time, then treated. In Miami County, Kansas, we have no obstetricians, gynecologists, CNMs providing women's maternity care or nowhere to go to have a baby. Lack of providers for women's health is a barrier to routine care and testing in Kansas. We have no family planning grant, which would provide free to low-cost services. We only have my limited women's clinic, which is not free because we have no grant funding. Attendance at this clinic is far below attendance prior to the loss of the grant. Cost is a barrier to routine care and testing. There are no OBGYN midwifery practices or places to deliver a baby from Overland Park, Kansas to Pittsburgh, Kansas. So you can drive right through Miami County, Lynn County, Bourbon County, Anderson County to the side, and they have no locally based maternity services and limited family planning grants. Distance to services and cost of travel is a barrier to care and testing. My county is not alone in this. 75% of Kansas counties have no maternity care services. No maternity services is a barrier to care. The data that we have is concerning, and you can see the Miami County data in my testimony, but incomplete. Local and systemic barriers. In face of all these barriers to care, expedited partner therapy can help us have an impact on the increasing number of newly identified cases by reducing ongoing transmission and preventing reinfection.
Thank you. And I thought I was a fast talker.
I would love to say.
And next we have Elizabeth, and I'm not going to attempt the last name, Elizabeth. I'll let you introduce yourself.
Hello, my name is Elizabeth Grunwig. No worries on the last name. I know it's a tough one. And I'm the chief epidemiologist for Wyandotte County Public Health Department. And I wanted to talk a bit about some of the concerning data that I'm seeing. So as an epidemiologist, part of my job duties is to track infectious diseases in the county and in the state, look for any concerning trends that we should be aware of. And for the last 10 years or so, I've noticed a lot of concerning trends regarding STIs. I think a lot of people in this room know that nationally, STI rates have continued to rise across the United States to the level that the CDC describes as a crisis and an epidemic. And the same trend is being seen in Kansas. In Kansas, our STI rates have nearly doubled in the last 10 years. And Wyandotte County has especially seen very high STI rates. Our rates continue to go up in Wyandotte County, and we have the highest STI rates in any county in the state of Kansas. So as a local epidemiologist, this trend really concerns me. And we feel like we need to take action to help benefit the health of our residents in Wyandotte County and across Kansas. We've had some of our other medical professionals talk about some of the concerns about STIs. There's a lot of serious health consequences if left untreated. For women, it can include pelvic inflammatory disease, infertility, ectopic pregnancies, and it can also pose a serious issue for women that are pregnant, including preterm birth. And especially for our unborn children, can have a number of health consequences like low birth weight, lung infections, eye infections, things like that. And so it's very important for us to take action for the health of our residents across Kansas. And really, EPT is an opportunity to put another toolkit in our medical providers' toolkit for trying to combat this crisis of rising STI rates. The CDC states that EPT is effective and safe at controlling STIs in the community. There's been a lot of research behind this practice. It's not a new practice. And in fact, Kansas is one of just 4 states that does not currently legally explicitly allow the practice of EPT. And so we have to question, why is it that Kansas is one of just 4 states and in the minority that's not currently utilizing EPT? It also has strong support among medical providers. Some of our most important medical associations, including the American College of Obstetricians and Gynecologists, as well as the American Academy of Family Physicians, have position statements supporting the practice of EPT. Also, as the epidemiologist, we conducted a survey across the state of Kansas among medical providers to get their opinions about EPT. We surveyed 155 medical providers, and there was overwhelming support for EPT from physicians, nurse practitioners, and more medical providers. So in conclusion, we strongly encourage you to support this bill. Thank you.
Thank you very much. And it's Gronway?
Grunway.
Gronway. Okay, thank you. And next we have Dr. Derek Totten. I hope I said that right. On WebEx with us. Thank you. Can you hear us, Dr. Totten?
How about now?
Yes, we can hear you.
Okay, I just have to hold down a button here. Yeah. Okay. Sorry for the technical difficulty. Madam Chair, members of the committee, thank you for your time today. My name is Dr. Derek Totten. I'm the KDHE Chief Medical Officer, and I am here to provide testimony in support of Senate Bill 404. A sincere thank you for this opportunity. Briefly about me, I am a lifelong Kansan, born and raised in Marysville. I attended KU Med for my medical training, for my MD, as well as my public health training. My path was aligned with two legislative priorities, the Kansas Medical Student Loan Program, as well as I completed my family medicine residency training at Smoky Hill in Salina. That program was created to help train family medicine physicians to enter rural Kansas. Since 2016, I have been practicing in rural Northwest Kansas, full scope family medicine with obstetrics in Colby. In my role there, I care for individuals affected by sexually transmitted infections, STIs, and their partners, similar to many healthcare providers across the state of Kansas. Expedited partner therapy, EPT, allows for healthcare providers to provide medication to partners of patients affected by an STI without requiring an in-person evaluation of the partner. EPT is not a substitute for a full sexual health evaluation, but partners of infected individuals often cannot or do not seek treatment. For example, men are less likely to seek treatment because they are less likely to have symptoms, but the issue there is they can still spread the disease. But early treatment and preventing reinfection of gonorrhea, chlamydia, even trichomonas will help mitigate transmission to everyone affected, including newborn babies. Kansas data from 2022 shows a total of 13,967 cases of chlamydia, up from 11,138 the year prior. Gonorrhea cases in the last decade have doubled. In 2012, we had 2,237 cases on file, and in 22, we are at 4,995. Left untreated, these diseases can result in infertility, ectopic pregnancies, a pelvic inflammatory disease, and in rare circumstances, life-threatening sepsis. Compared to the practice of standard partner referral, EPT will increase the ability to treat partners in a cost-effective manner. Of all the 47 states who do allow EPT, none have reported any major adverse effects, further demonstrating the safety of this practice. Many healthcare providers in Kansas support EPT. They have in the past and continue to do so now. KDHE supports Senate Bill 404 because it will allow Kansas healthcare providers yet another tool in their toolbox to safely treat Kansans affected by these diseases. Thank you for your time.
Thank you very much. We understand somebody's having difficulty with WebEx, so we're going to go to Jill Bergen. And she is on, the rest of these conferees are going to be on WebEx. Is Jill on with us?
Yes, can you hear me?
We can.
Okay,
Please
wonderful.
continue, Jill.
All right. Good morning, and thank you for your time and consideration of this important topic. Again, my name is Jill Bergen. I'm a family nurse practitioner. I currently practice at Heartland Community Health Center in Lawrence. and I am providing my testimony today as a proponent of expedited partner therapy. Currently, I practice partly in primary care, but I also practice in family planning. I am the Title X family planning provider here at Heartland. And previously, I also worked in the Title X program at Lawrence Douglas County Public Health as an RN before this program transitioned over to Heartland. And as such, I have been providing sexual and reproductive health care to low and no income, uninsured and underinsured individuals here in Douglas County for the last few years. Sexually transmitted infection care and treatment is a core function of Title X care, and it helps individuals reach reproductive well-being, prevent transmission of STIs, and prevent adverse health outcomes. Untreated STIs can lead to pelvic inflammatory disease and infertility. Partner treatment is critical to effective care, prevents reinfection, stops the spread of treatable infections, and prevents long-term damage to the reproductive system. When EPT is explicitly allowed by law, we can use our best judgment as providers to provide treatment quickly and effectively for our patients' sexual partners. Studies have shown EPT to be safe and effective. It's used throughout the country without safety concern, and it's well supported by the medical community, both locally and nationally. Because it's not explicitly allowed here in Kansas, partner therapy can be delayed, difficult to access, or worse, may not happen at all. Just this week, I've had patients whose care was delayed while they waited to access a visit after their partner tested positive for an STI. This put their treatment timeframes out of sync with their partners, which puts them at risk for reinfection if they don't fully understand or abide by our careful patient education about their abstinence timeframes. Additionally, EPT would ensure that partners are treated for the correct infection, because sometimes patients present after being told that their partner has been tested positive for an STI, but they don't always know which infection their partner tested positive for. So when we consider that STI rates have risen significantly in the state of Kansas over the last decade, EPT only makes sense to help reduce the burden of STIs in our communities, healthcare system, and state. The legal gray area that arises from not explicitly allowing EPT is a current barrier to care and treatment. So I just would like to encourage you to really support that, and thank you again for your time and consideration.
Thank you very much for your testimony. Next, we're going to go to Jessica Kiefer. Jessica, are you online? There you are.
Yes, I'm sorry. Forgive me, I'm on call today, so hence my unprofessional attire. I
would say that is your profession, so that is professional attire. Thank you for being with us. Please continue.
Thank you. Thank you very much, Madam Chairman, and the rest of the committee for hearing us today. I thought this was very important and wanted to make time in my day to be here to testify as well. Again, my name is Dr. Jessica Kiefer. I'm a practicing OBGYN at Stormont Vale Lincoln Center, just down the street from you all. I have been practicing there for the last 2 years. I see these sexually transmitted infections in my practice daily, and the inability to treat my partners directly impacts my practice daily. And I am speaking today because I'm very much in support of expedited partner therapy and would ask that you all consider supporting this bill as well. I was part of the effort in 2021 to pass expedited partner therapy and continue to support it today. As you can tell, I'm very passionate about this topic. There are many of us who do go ahead and prescribe expedited partner therapy if we can get our patients' partners to come into the office and speak with us. But it would be so much easier for us if that we could call those patients or make contact with them in some other way to expedite treatment for our patients' partners in order to benefit the health and wellness of our patients. Some examples for you just from this past week. In my practice, I took a fallopian tube out of an 18-year-old this week that was chronically occluded or blocked due to chronic pain due to persistent reinfection. I have someone hospitalized that I just saw today who has a very large abscess in their pelvis requiring IV antibiotic therapies due to persistent reinfection. I saw a patient just yesterday in my office who had chlamydia for the 3rd time in her pregnancy, and she's only halfway through. I'm very much troubled by this because this very much increases the risk to her unborn baby in her pregnancy. It increases her risk of preterm labor. It increases her risk of her water breaking early and passing on the infection to her baby. as you can see, these examples have harrowing effects on the long-term health and wellness of my patients. And I believe that expedited partner therapy would allow for me to treat my patients' partners and reduce these infection rates that are rising in the state. 96% of my colleagues and everyone in my practice are very much in support of expedited partner therapy in order to work to decrease neonatal and maternal morbidity and mortality rates within our state. Again, I very much appreciate your time today, and thank you very much for considering supporting this bill.
Thank you very much, Dr. Kiefer. And next we have Dr. Jennifer Schrimsher. I hope I didn't butcher your last name. Are you with us? She's not on. Do we have Dr. Bristow on yet? No, he was having difficulty. Okay. What about Dr. Kimberly Swan? Right, would you let us know when one of these folks gets on to WebEx? In the meantime, committee, do we have questions for the conferees? Senator Holscher.
Thank you, Madam Chair. Maybe Dr. Allen? Okay, so from the testimony that was submitted as well as people that were here testifying today, it sounds like this is a rural problem as well as an urban problem. It sounds like this is a safe process utilized in 46 other states. Additionally, it sounds like there are serious health risks if this is untreated, including risks to newborns. So I'm just wondering, like, what are the potential negatives of implementing this?
You know, in the medical community, this is not controversial. This is not contested. I struggle to understand any potential negatives. The biggest one that I worry about would be potential allergies. But there's that extra layer of protection at the pharmacy. When the partner goes to pick up their script, the pharmacy always verifies allergy list, as well as the patient would obviously not take a medicine that they're allergic to. So I think that's the biggest worry. And then detailed in the bill is several education points, such as not taking doxycycline while pregnant. So the bill requires that a provider prints out that education and gives a written material to the patient to hand to their partner. So any additional medicine that would be dispensed would also be dispensed with that education that I think would alleviate any of those safety concerns.
Great. I'm kind of struggling to figure out why we are lagging behind with 46 other states implementing. Thank you.
Absolutely.
Senator O'Shea.
Thank you, Madam Chair. I have a question for Jenna and then just a comment. So my question is, earlier this year, my family and I, we all woke up with fevers, and my husband stayed home. Me and my son went to the doctor, got tested positive for influenza A. We knew we'd been around a baby 2 days before that had the flu. The doctor, I don't know if this is legal or not, but said, we know your husband has it, right? He had the same symptoms of fever, and he'd been a patient, so sent home the medicine for him too, even though he didn't go and see the doctor. I'm curious if that was legal, because it feels somewhat similar to this situation, or the pharmacist, if you'd like to speak to it too.
Dr. Allen, I see your hand raised. Would you like to come? And we'll relieve Jenna.
Absolutely. I think that's an excellent point, and I think that illustrates that this type of practice is legal and it is accepted, and there are situations where doctors need to be empowered to prescribe outside of that standard doctor-patient visit relationship. So treating a family member who's been exposed to flu is one of those examples. Treating sexual partners for STIs is another example. I think the issue is that providers are scared because they look at the CDC map and they see that Kansas is one of these states where they don't have that protection. And so physicians want to be able to step into this space, but aren't sure of the legality specifically for expedited partner therapy. So that's our ask, is that we would provide legal protection for something that's already standard of care.
Thank you. We were so thankful. I wasn't about to tell anyone if it was illegal because,
Who was that doctor?
we were practically crawling into the doctor's office, so thank you. I just wanted to comment that this time what struck me more than anything is that this is disproportionately affecting women. Being pregnant, also just hearing about pregnant women being reinfected, having to worry about going into labor early. So I really want to encourage our committee to work this bill as it's very much disproportionately affecting women.
I've just been told, committee, that Dr. Bristow is on the line with us from WebEx. Can you hear us, Dr. Bristow?
I can. Thanks for having me. Can you hear me okay?
Yes, and you have 3 minutes.
Perfect. All right. I'm Dan Bristow. I'm one of the OBGYN residents that work at Overland Park Regional Medical Center. I have the privilege of taking care of women, not only women who are in their 50s, 60s, but also pregnant women. And that's the majority of patients that I see. What just was highlighted earlier, this issue primarily, especially in my patient base, affects women disproportionately. A lot of patients who we actually see, we screen in the first trimester. This is how we find untreated, usually venereal diseases, gonorrhea and chlamydia. And so we test them for all our patients in the first trimester. And then of those we find, we treat, we do a test of cure in 2 to 3 months. However, a lot of our patients are underserved, on Medicaid. We have a disproportionate number of patients who also have partners who are unwilling to go to the health department. It seems like it's laborious. When I've asked them about whether or not their partner would seek medical attention, they said probably not. And so I've run into this situation quite a few times, actually. And so we do know that infertility rates increase with untreated pelvic disease. We do know that while pregnant, increased risk for preterm labor, but also premature rupture of membranes. I'll never forget a patient who was 22 weeks, came in ruptured, and that can be catastrophic to the health of the baby, has extended NICU stay. About 50% of patients who have their water broken at that week go into labor, and then they have themselves a 22-weeker. If not, they stay inpatient until 34 weeks. That's 12 weeks of cost to the hospital, honestly, and they're on Medicaid, so we pay for it. And so it happens to be, whereas you could just offer a $2 pill one time to give to the patient so that they can have their partner treated, men are very unlikely in relation to be tested because most of them are asymptomatic, and we don't test them, at least in my practice. So I'm in favor of this bill, and I think that it is a grand slam. It's a knockout, and like as was highlighted earlier, we've got 46 states backing it. Thank you.
Thank you. Do we have any of our other 2 conferees on WebEx? I should say either. Not yet. Committee, other questions? I think I almost said Dr. Petty. Senator Petty.
Thank you for that upgrade there. So my question is for Dr. Totten, who's here with us. Or no, he's on WebEx. Dr. Totten, in your testimony, you talked about...
Excuse me, is Dr. Totten still on WebEx with us?
Yes,
All
ma'am.
right. Okay, thank you.
So I would just like to expand. So I noticed in your testimony, so are all of our neighboring states, have they already passed expedited therapy legislation?
Oklahoma has not. Legislation has been presented in Oklahoma this year, however, and the other states include Oklahoma is a neighboring state that does not. However, there is legislation that's been proposed this year, and I'm sorry, I can't remember the other two off the top of my head right now.
South Dakota, Alabama, and Rhode Island.
So only our neighboring state would be Oklahoma. And Dr. Totten, but thanks for that list of those that have not. Dr. Totten, in your testimony, so in the bill, it does, could you expand on the fact that in the bill, doesn't it allow for the physician to determine whether that sexually transmitted disease is appropriate for partner therapy?
Could you please clarify more?
So in the bill, doesn't it, I was looking at on page 1 from lines 30 through 34, that this bill does allow for the health provider to determine whether the treatment would fit for expedited therapy.
I see. The medical appropriateness then?
Yes.
So, when I look at this bill and this practice of EPT, this is something where we'd support this as essentially having another opportunity or avenue for treatment of patients. That being said, even if this were to pass, there may still be medical providers that feel more comfortable given unending possibilities of clinical scenarios where they would actually prefer to see that patient's partner in person or have that person be evaluated depending on certain circumstances underlying individual cases.
So the legislation doesn't mandate that they have to do this?
That's my interpretation, yes.
Thank you.
Committee, other questions? Dr. Steffen.
Thank you. For Elizabeth G., I am looking at her map, the Unified Government Public Health Department, and with the states that you can do this, the states you can't. And I think the statistics need to be fleshed out a little bit more. We've certainly defined that the diseases are very problematic. Let's flesh out whether this process works. You talked about the incidence of STDs going up everywhere. They're going up in Kansas. Aren't they going down in the other states where this is being done? Are they disproportionately going up in these 4 or 5 states? What are we seeing as to that we could really say this is effective? Because this is clearly a degradation in quality of care, whether we want to admit it here in this group or not. When you start doling out medications to people you've never seen, met, talked to, any of that, that's a lower quality of care. So I would like some evidence that this works rather than it's just something we're all behind.
Right, yeah, that's a valid point. And I think, first of all, it's good to think about EPT as one tool in a toolbox. So EPT alone is not going to fix these, crazy high STI rates in Kansas and in Wyandotte County, but it's another tool that we can give our medical providers to help combat this issue. And also there is evidence from the CDC showing that it reduces reinfection rates. There's been a lot of different peer-reviewed studies done that shows that EPT does reduce partners being reinfected somewhere between 20 to 40%, depending on what study you're looking at, but there is data behind this that does show that reinfections are reduced. Obviously this is a national epidemic, the national epidemic of STI rates going up, and so no state's really, necessarily successful, but again, this is another tool in our toolkit to help combat this issue.
Thank you. I would like to see those studies, and I'd like to see the studies where it shows follow-up and complication assessment and that sort of thing as well, because all of that is theoretically easy to track. Now, in this population, it could be difficult. Since our chairman is busy, I'll take the time to ask one more question. Since 2020, and with this bill, this kind of further ingrains my thoughts. And question is, what role does informed consent play anymore in the healthcare field? And that would be more for the physicians. Does informed consent mean anything anymore?
I'm going to
Yes.
ask that you wait to be called upon to answer a question. No, that's okay. Did you call upon him?
I threw it out there.
Threw it out there. The reason no, that was kind of you. It's just we have somebody on WebEx who raised their hand to answer the question. So, Dr. Kiefer, you had your hand up and you were going to respond to Senator Stephan. Is that correct?
Yes, thank you very much. I would just like to add and perhaps reframe the comment regarding degradation of quality of care. I completely agree with you, Senator Stephan, that the standard of care is to see a patient in the office, examine them, and adequately counsel them. And that would be the goal, even with expedited partner therapy, would be to encourage patients to come in and be examined and counseled in person. The purpose of this bill with expedited partner therapy is not to take the place of that. I completely agree with you that that is first and foremost the most important way to counsel a patient. However, some care is better than no care in this particular situation when patients are going untreated despite our recommendations to be seen and examined. And so talking to the patient on the phone, providing informed consent, and counseling them whether or not they can come into the office in person is the desire behind supporting expedited partner therapy. I hope that provides some clarification.
Thank you. And Dr. Allen, did you have something that you wanted to add? Nothing to add. Thank you. Are either of our other conferees on WebEx? All right, committee, other questions? Senator Erickson.
Thank you, Madam Chair. My apologies if this has already been addressed, but I'm reading section B2 and then the information that must be provided when you do EPT. My question is there any verification that the partner received the information that was sent with the patient or the medication that was sent with the patient? Is there any follow-up or verification that the partner received that material?
Is there a particular person you would like to respond? Or anyone who would like to come up that raised their hand to respond?
Madam Chair, to me, that is a concern. I mean, I agree with the intent, and I think we should do, but my concern is, I can think of a dozen scenarios as a former school administrator where that medication and information is not being distributed to the sexual partners for a variety of reasons. And so that's my concern, that is, whose responsibility, and should there be follow-up to make sure, to Senator O'Shea's point, you've got a pregnant partner who has these health risks, and you're assuming that the patient is going to give that to a pregnant sexual partner. You don't know if they have or not. And so that's my concern, is if there's any follow-through to make sure that the partners are getting that information. Thank you, Madam Chair.
Dr. Kiefer, you raised your hand to respond.
Yes, thank you again, Madam Chairperson. My understanding was that the patients are still going to be receiving counseling at the pharmacy regarding the medication, so that could be one stopgap in this. And my understanding again of the bill as written, and perhaps someone can correct me if I'm misunderstanding, is that we are still required to counsel the patient partner prior to prescribing treatment. It just would not necessarily be in person. And so I would not be able to prescribe to a patient's partner, for example, if that patient does not give me permission to contact their partner and provide that counseling on the phone.
Thank you. That's helpful.
Thank you. Yes, Dr. Allen.
I understand the concern, when a patient is diagnosed with an STI, of course, there's a concern about whether or not they were disclosed to their partners, and be honest about that. There was a study that when expedited partner therapy was offered, that partners were more likely to disclose that infection to their partners. So it went up from a 68% disclosure rates when expedited partner therapy was not offered to 90%. So I think this removes some of the barriers and kind of lessens the blow of having to tell your partner that you've exposed them to an STI when there's a treatment option available. So
I have a few questions, and I do have a few people that I would like to address these to. One of my questions is actually regarding a testimony that we received from Rochelle Colombo with the Kansas Medical Society. And in it, it mentions that, let me pull that up here real quickly, that under current law, we cannot, that basically the doctor must see the patient. It says under current law, a physician cannot treat a patient they have not evaluated regardless of their exposure. But yet we heard it said that this is common practice. Could somebody address that? Thank you. I know, seeing no hands raised. Then the third question that I had was, I'm sorry. Dr. Totten, are you available?
Yes, ma'am.
Okay, could you answer my question about that?
Yes, I'd be happy to. This is an area where if I feel like if you were to solicit physicians in Kansas, amongst healthcare providers, and not just physicians, this is a practice where a lot of times subscribing to the practice of EPT makes sense to a lot of individuals who may even potentially be unaware of current statutes in Kansas that should technically prevent the prescribing of partner therapy. That being said, it would not be shocking to me if certain healthcare providers were also performing EPT in manners consistent with the law, but conducting an exam over the phone or something that in my mind doesn't really technically live up to what the current expectation is in Kansas. However, I think some physicians and other healthcare providers see the current rules and regulations as a bit of a gray area. And so I believe that's where Ms. Colombo is coming from with her statement that some providers will take it upon themselves, regardless of current statutes, to interpret current laws, I suppose, in a way such that they can still provide safely therapy for partners.
Thank you for your response. And of course, we both know rules and regulations can be gray, but laws are not. So I appreciate your response. My third question is regarding, was Jill Bergen. And Jill, you mentioned that that this treatment prevents reinfection. Does it? I didn't realize that.
Yeah, when we have patients that test positive for something like chlamydia or gonorrhea, we do know that these treatments are curative treatments for these. These are standard treatment guidelines provided by the CDC. We know that these treatments are curative for these infections. And so if we provide partner treatment, we also know that we treat partners. And so they do prevent reinfections, especially if we treat partners at the same time that we treat our primary patient. And they are treated at the same time and on the same timeline. And they abstain from sexual intercourse for the prescribed amount of time. We do prevent reinfection.
I think I understand now. So it's not like once you've had measles, you can't get measles again.
Exactly.
Not that one could be reinfected. It's just that less likely if the partner is treated as well.
Yes, these are bacterial infections that require antimicrobial treatment.
Thank you. My next question is for Jenna. Couple of questions. Yeah, we said that, say within the bill that the provider must provide this information. Does the pharmacist, going back to Senator Erickson's question, is the pharmacist, if they're aware, is there any indication on the prescription it's for EPT? And does the pharmacist give additional information when they come to fill the prescription?
Thank you, Madam Chair. There is nothing in the bill that specifies a special designation on the prescription. However, I am generally familiar that a prescriber can write in notes to so a physician could write in like notes when filling the prescription that could be given to the patient.
And then, thank you. And my final question, Jenna, is on page 2, line 8 of the bill, talking about the 16-year-old may give consent. Could you read that to us?
Yep. The bill states that a child who is 16 years of age or older may consent to receive expedited partner therapy when no parent or guardian is immediately available.
Thank you, committee. We are out of time. Thank you so much for all of you being here with us today. And this closes the hearing on Senate Bill 404. And committee, we are adjourned.